Welcome to Flip Your Script, the vodcast from the American College of Lifestyle Medicine that's all about clinicians redefining care through innovation, leadership, and lifestyle medicine. My name is Dr. Padmaja Patel, and I'm the current president of the American College of Lifestyle Medicine and serve as Chief Medical Officer of Nudge Health. The future of healthcare isn't being written in policy briefs or press releases. It's being written by clinicians who dare to prescribe differently, by leaders who rebuild systems from the ground up, by patients who reclaim their health when someone finally gave them the right tools. Each episode of Flip Your Script brings you 5 key takeaways from people living that story, because the best way to change medicine is to hear from those already doing it. In this episode, we're honored to be joined by Dr. Vivek Garg. Dr. Garg is President and CEO of the National Committee for Quality Assurance, NCQA, an independent nonprofit that has championed better healthcare for more than 35 years. With more than 15 years of experience as a physician and healthcare executive, Dr. Garg is dedicated to improving quality of care and helping people live fuller, healthier lives. He has served in senior leadership roles at organizations driving innovation in care delivery, population health, and tech enablement, including as Chief Medical Officer for Centerville Senior Primary Care and Care More and Aspire Health. He also held clinical leadership positions at Oscar Health and One Medical and practiced as an internist and PCP. Dr. Garg brings additional perspectives from academia, consulting, and policy. He trained in internal medicine at Brigham and Women's Hospital and worked at McKinsey & Company and Medicare Payment Advisory Commission. He earned his MD from Harvard Medical School, an MBA from Harvard Business School, and a BS in biology from Yale University. He's board certified in internal medicine. Welcome, Vivek. Thank you so much for joining us today.
Thank you, Padmaja. It's a pleasure to be with you. Thanks for having me.
My pleasure. So before we get into big systems questions, Vivek, I wanted to start with you. You moved through primary care, value-based care, prevention. That's a lot of different vantage points. What experiences along the way really shaped how you think about what primary care actually needs to thrive?
Yeah, thank you, Padmaja. It's such a great question. I know you and your team bring such great purpose to your work. For me, I'll start on the personal side. I'm the son of an immigrant physician father from India. My dad and mother moved to Canada and then Alabama, where I was born, and then to New Jersey, where I grew up. My dad is that classic community doctor specialist. He did ICU, floor medicine as pulmonary consult, outpatient pulmonary and primary care, nursing home care and support, sometimes all on the same day, 6 or 7 days a week for decades. And so I really grew up spending time with him in the healthcare context. You and I know the commitment that clinicians make in practice in that mode. So I would go on weekends and sit in the doctor's lounge at the hospital.
Yes.
Went on home visits with him. And, in addition to being a really stellar doctor who was triple boarded, I just saw how important he was to people. Really a fixture of the community, the respect, the support, and how seriously he took it and how much meaning he got from it. And so that really affected me. I kind of went on the pre-med track, went off and went back on. And the other personal experience is really my mother's journey. My mother has suffered for a long time from what was initially undiagnosed and unmanaged bipolar disorder. And over my life, she had severe episodes where we had to confront her, bring her into psychiatric care, sometimes against her will. And over time, I saw how that affected her chronic conditions, because like many people, she developed diabetes and high blood pressure later in life. And the intersection of psychiatric crises with those conditions, ultimately has landed her on peritoneal dialysis with complete kidney failure. And she's doing well and everything's stable and very fortunate. But, that really affected how I think about the patient journey and whether the system we have is really a system, which I don't think it yet is. And so as I went into medicine myself, I decided to practice primary care after getting some policy and business exposure, joined One Medical Group. And what I fell in love with at One Medical and Oscar was really truly the focus on the patient or the member as the primary point of engagement and leveraging technology and data to support that, and then wrapping things around them and really building for them. And then in the last decade, prior to the NCQA, I've spent my journey at CareMore and CenterWell in value-based care.
Right.
And there, I've seen personally and led teams where we see so many seniors who show up in the office as a new patient on a dozen medications, and they don't really know why.
Right.
They've gone along. They have a very surface level understanding. And so many of my colleagues or in my own interactions with those patients, you'd find out no one has ever really had an in-depth conversation with them about the context and adjustments and other avenues they could take. And I think this is why I'm so aligned with the mission you bring at the American College of Lifestyle Medicine. I've worked with so many other clinicians where they say, I wish we could have cared for these patients 10 or 15 years earlier. No one has had these conversations. And then you can start to unpack the complexity of their lives, think about how to contextualize the support, and you can unwind things. You can bring in non-medication related interventions. You can see that kind of unfold. And so all of those experiences together I really do believe the patient should be at the center of our work. And better outcomes take time and partnership to deliver.
Right.
And we've got to create the ingredients for that kind of focus and success through the systems we're all part of. And I'll just wrap by saying that's part of what brought me to the NCQA. Now I am also focused on the system level of that opportunity. Specifically, how do we build the quality architecture that creates the framework in which patients and care teams can bring that longitudinal, deep, personalized focus over time. And we can see that shift in the outcomes that truly matter to people, not just the ones that matter in a policy briefing. So I think the accountability we all are trying to bring has to come with the understanding of what it takes to truly help people achieve healthier and fuller lives, the time and effort and care that it takes, not just the stack of interventions or the list of procedures or codes or medications.
Right. I love that. I love that answer. So you talked about value-based care, and we know that it was supposed to be the answer to prevention, and theory made sense. So I don't know what happened in between, but because what I hear from clinicians on the ground that they are being held accountable for outcomes without the investment to actually move those outcomes, right? Not having enough support. Where do you think the biggest breakdown is happening right now, and who owns it?
Yeah, it's a great question. I mean, I tend to think that value-based care can work, but then we need to understand the boundaries of limits of it and in its current construct and continue to evolve those. I personally spent this decade in groups like CareMore and CenterWell because I think when you have the payment model aligned with a population view, teams can be supported to build more of the resourcing and clinical focus. So it's both other skill sets and interventions, but it's also more time, smaller panels, more depth of engagement, more frequent engagement. It's still not enough. So I want to acknowledge that concern that you hear, and I've also felt, because you still hit this limit. And, I'll give an example, which is I had a colleague at CenterWell, very experienced physician and medical leader, really personally took in the proposition of helping people on their lifestyle interventions, wanted to build that more into our practice and started to help doing that. We were all on board, but just felt like he wanted to go further. And so he actually left at some point and is considering building his own lifestyle medicine focused practice, which I personally was very supportive of or tried to be. Still a loss, you can imagine, as a leader. But I think we have to acknowledge that people have these deeper needs, and we're not quite sure yet or set up yet to have the operating environment. I think value-based care means a lot of things. I think the evidence shows that when you have more of that global capitation or full risk or total cost of care, or even just bigger chunks of it, then you get more of the rewiring and the financial flow alignment that can create these enduring care models and teams. I think there's also value-based care light, which can just be upside bonus savings at a kind of minimal level. And that's kind of stacked on top of fee for service. And while that kind of meets where the system is right now for many people and practices, it doesn't give them the room or the budget to do this fuller rewiring that I think people needed. And then I think in line with this theme of we need to create enduring, consistent focus over time, because that's what it takes with patients and all of us to change our trajectories and have that support. We need continuity in every level of the system. We need coverage continuity and stability. People need continuity with clinicians and the care teams. And to do that, the care team and clinicians themselves have to be stable with continuity. And unfortunately, I think we're in a moment where there's friction and churn at all levels of the system. And so you kind of look at an individual patient with an individual specialist or PCP team and say, it's really hard to have that multi-year stability. And I think that's a core thing that we all need to shine a light on and find policy levers and operating levels and levers to shift back towards more continuity and stability, because then it can all line up better.
Yes, well said. And talking about friction, I think there is something that I find myself talking about a lot. Every payer has their own signals, their own measures, their own definitions of success, and the primary care physician is stuck trying to serve all of them simultaneously. If we could get even a handful of major payers aligned around a small set of prevention-focused metrics, how would that change, and what would it take for us to actually get there?
Yeah, this is one of the biggest themes I'm hearing just 4 months into my tenure at NCQA is both, I'll say frankly, candid feedback about the role our constructs sometimes play in creating more things to look at and report on and drive improvement on. But I think you could also look at HEDIS as an example and say it is one of the most consistently uniform deployed sets of quality signals in the country and has played some role in alignment.
Yes.
But we certainly need more, because the situation you're describing is absolutely real. I think it's going to require us to convene and talk about things differently and talk about the value of alignment and harmonization to creating the kind of longitudinal focus and impact on improvement that we need. That's going to require stakeholders to make different choices to achieve that outcome, not just NCQA, but health plans and health systems and policymakers. I think it's very much possible. I've been cautioned by very experienced people in the quality and policy for ecosystems that they say, Vivek, others have tried. Good luck. We wish you well. And so I'll say I'm going to help try again because we can't have that friction. And the metaphor I sometimes use is, I think when groups like the NCQA started off 35 years ago, there weren't really quality standards deployed in many of our clinical areas, in health plans and other areas. There wasn't a uniform measurement framework or parts of it. And so we were really in the dark. We couldn't tell what good looked like. We're in a different moment now. And say we've gone from the darkness to having 1,000 lights. And now, but the 1,000 lights are all pointing in different directions.
Yeah.
So we're all being struck by the glare and don't know where to go. And I think what people are looking for now is more of a chain of lights, something that gives us the ability to see how populations are trending over time. If the first thing happens, does the next thing happen? And does that lead to the improvement in that patient's quality of life and health that we're all seeking? And so one part of it is measurement, cohesion, alignment, and harmonization. Another part of it is just going to be convening the people who operationalize these constructs to say, look, alignment is going to drive a different type of value, but it's going to mean fewer things that we're all stacking hands on, because that means the patient and the care team and clinicians get something that they can rely on that's consistent. So I think we all need to try again to achieve that. And then when it comes to prevention, proud that HEDIS has some of the most commonly adopted prevention metrics that are deployed across healthcare: cancer screening rates, vaccination rates, chronic disease management risk screening rates in different areas. I don't think yet we're oriented in that chain of lights fashion. And so there are other aspects of prevention and early risk management that we should all think about and talk about so that we can embed them into the measurement framework. Because again, I'll go back to what my CenterWell colleagues told me. Yeah, I wish we cared for these patients 10 years earlier. We could have helped them bend the curve, and they could then enjoy their next phase of life with more of that functional health that they're seeking now. And some of it's addressable, and unfortunately, you and I know some of it hardens and sets in and can't be.
Yes. So speaking of alignment, what about universal foundation of measures? What's your opinion? Do you think it's going to probably help us as we see more and more programs being adopting that?
Yeah, the NCQA has been a big proponent of this kind of alignment and the universal foundation as a construct. I'll say personally, I look at it and say that is a good architecture, and we should all keep moving towards concepts like that. I'd say the one thing I think personally sometimes is, are there population-specific versions of it? Because I think you could credibly look at stars and say, well, there's many common good things in stars from a clinical perspective. There's not as many senior-specific insights or quality performance measures yet. Or if you go to working adults or children, just how do we think about the bundles that matter? And there's certainly some bundling that exists across healthcare, but it tends to be organized by coverage dimension, not by population clustering and similar needs.
Yeah. And Vivek, I really appreciate that you are such a big lifestyle medicine champion. But lifestyle medicine exposes something the payment system would rather not confront, right? The work that actually changes lives doesn't have a billing code. The coaching conversation, sometimes take 45 minutes or so. Health coaches are still not getting reimbursed. The follow-up call that sometimes can really change patients' journey. Or sometimes, thinking through that time you spent on behavior change, right? All of this is still invisible, unpaid. And you've been in this system. So I want to ask you, how can we really change this payment models, and how would it be actually finally aligned with the kind of work we do? What would it take?
Yeah, I think it's such an important point, and I sometimes think of it as great clinicians do so much more than they're reimbursed for their patients. Many of the examples you gave, I remember early in my career at One Medical, being a new PCP and being a medical director and tracking my own Net Promoter Score, and I could see the trends for everybody else in aggregate because I was in a position where I had access, and it drove me crazy that I wasn't the best. I wasn't bad, don't get me wrong. And what I learned was one of the highest rated PCPs at the time at One Medical, he called every patient the day after their visit.
Wow.
And that created just such a different sense of caring for people. And then it showed in a simple construct like Net Promoter Score. And so I think your point about the touches and time it takes for anybody, whether they have complex issues or not already, is just so important. And we value time through these billing codes. And so they encapsulate some things and not others. So I think one part of it is to align on patient notions of quality, which include the sense of caring and kind of support. A lot of people don't know the power of what behavioral and lifestyle modifications could present to them once they're on a risk trajectory. And you and I know many people are surprised by a new diabetes diagnosis. We have all the right tests, all the right knowledge, all the right availability in many cases, not all, and yet it's still a surprise. And then you and I know how many times people look back and say the trend was there, but it wasn't discussed, or it wasn't effectively managed, or lost to follow-up, and all these concepts. So I think one part is we do have to value the outcomes, and I think liberate the payment to allow for people to experiment and build these kinds of touch points and interventions and staff up. I don't know if that'll be enough. I do think that some of the specific activities that I think your organization has codified and highlighted the evidence on need payment through fee-for-service through them to help activate the front end of engagement. And perhaps through the combination of those two things, moving into more population level accountability with higher investment so that people can rewire and start to do more of these things in primary care or otherwise, along with the front end of, we can't wait forever for those things. So there's some activities that are so evidence-based that they should have payment now. I think that kind of brew could be interesting to think about.
Yeah, and I think as we see the trend from CMMI models, especially Access, which talks about outcomes aligned payment, what's your take on that? I personally think it's really the way we could shift the mindset of clinicians finally, because many of us are still used to billing for services or encounters rather than focusing on outcomes. So it may be a good way to really shift that thinking around creating value instead of just focusing on volume. But I wanted to see what do you think about that?
I've had so many amazing conversations with fellow clinicians about when they're presented with data about their panel and how their panel is quote unquote performing. When it comes to clinical outcomes, there's tremendous focus. We all care about it so much. It's why we do these things. We want people to have that benefit and improvement. It's why we train so long. It's why we show up.
Right.
And so I think it's such a important aspect to bring to more of the care teams and clinicians across the country, which is, how are your patients doing when they're not in front of you? And over time, are they achieving the kind of evidence-based care and outcomes improvement that we aspire to and know might be possible through the kind of care and interventions that we're capable of? Now, there's also a lot of debate that comes with any data, and I think appropriately, because we don't yet live in a world where there's fully interoperable clinical data. Yeah. We've spent a long time trying to make more of claims data than it can probably bear. And so this push that NCQA has supported, CMS and HHS are very much advocating for and driving on to get that digital data interoperability system really into reality. I think is hugely important because it'll unlock more of the richness of the kind of patient and clinical outcomes that really matter to clinicians and matter to patients, and make it fluid and available kind of in the water as we do our work. I think there's also the notion of, what do people think of as good outcomes for them from a less clinical perspective? Are they being cared for? Do they feel like they have a responsive care team? Do they feel like there's good coordination? And one of the things I know our team's talked about that we're very proud about at the NCQA is our emerging person-centered outcomes measure framework, which we've developed in support with Duals Plans and the John A. Hartford Foundation, which is essentially a container for patient-level goals. You identify goals, you establish follow-up, you put it on a scale, and you track whether you're gaining improvement or attainment. And that could hold the lifestyle medicine 6 pillars of focus in it. It could hold this age-friendly 4Ms construct. It could hold both. So things that are sort of completely unstructured right now in most care management care plans or clinician care plans can become more visible, aligned, trackable, and then ultimately work in support of people as they work on person-centered goals and support them in it. So I think we need a mix of data-driven clinical interoperability to get to, if I'm a cardiologist, is my panel of patients with heart failure, how are they performing?
Right.
Many people have no idea.
Sure.
And I don't think patients think that's the case, but that's unfortunately the case for a lot of the care that happens. If you're not in view and someone's not thinking about you right then, and then we give clinicians so much data they don't want or that isn't useful for them about all these other non-clinical aspects, I've never seen a clinician who didn't care about their clinical indicators for their panel. And then they can drill in and find a lot of issues with the data, and they can find a lot of reasons why it might be hard to move. And that's why I think we have to think about the personalization of goals and measurement as well over time.
Right. One thing I want to say, I've been a huge sort of proponent of saying that lifestyle medicine offers that high value clinical framework, and it could be perfect for the financial model that the value-based care models offer. Yet we know there are many barriers. And so I want to ask you, what would it take? How could we redesign value-based care that can really become that awesome ground for lifestyle medicine clinicians to thrive? What changes we need to really still implement within those models?
Yeah, I think it's a great point. Having worked in those models, I think you have to make it a part of the value equation in a very concrete way. So some of the things we talked about, like name it, label it, and reward it, both the evidence-based activities. And then I think as we think about how we look at panel and population goals and measurement, should insert this person-centered framework and weight it. We should also be looking at how much disease did you slow the progression of? How much early risk did you catch and change the trajectory on? And so because in value-based care, you do get that benefit of the total cost of care stewardship aligned with population management, but it can kind of make the two aligned sometimes also. Yeah. And so we need to be looking at goals and insights and measures that support slowing of progression over time, risk modification, in addition to the front end of activities, obviously polypharmacy, and we should look at medication burden as well. It's not just are you on the right 12 medications, but are we doing the things that we know can help you to be on fewer medications, right, and still be as healthy or healthier. And so I think there's concepts that are prevention and early management focused that should come in. And then there's a whole separate side, which maybe isn't separate per se, which is how do we help people activate on these concepts and opportunities when they're not in front of a clinician? Right. And how do we do that in a diligent, meaningful, evidence-based way so that their awareness and education level is there, but their ability to get the kind of coaching and support that they need doesn't always have to be tethered to a traditional office visit with the clinician.
Right. Yeah, so I want to end with something Sachin Jain, who I know, we both know very well,
yes,
has said more than once that ACLM should develop its own lifestyle medicine star ratings. And I think he's onto something. We know HIDIS measures have done remarkable work on chronic disease management, but there is a striking gap upstream. We screen for food insecurity, but not for nutrition quality. We flag tobacco, but don't systemically measure whether adults are moving, sleeping, or socially connected. So the 6 pillars of lifestyle medicine are exactly the behaviors that can prevent and sometimes reverse some of these chronic conditions. But yet they're largely absent from our measurement infrastructure. So I want to leave you with this. As NCQA looks ahead, is there real appetite to close that gap? And could lifestyle medicine behavior measures finally earn their place in the quality measure portfolio?
Yeah, I would go broader, Padmaja. Well, I don't think it should just be for seniors.
Yeah.
I think it's for all of us.
Starting from children, pediatric population as well.
And
yes,
these are the behaviors and focus. And when I first started practicing at One Medical, I had a great colleague who was our clinic medical director. I would go curbside her between visits or just chat with her. And I was talking to her about a couple of my younger patients, and she said, Vivek, I just learned over the last few years, sometimes what our patients early in their journeys need is a mother. And it was a little paternalistic to say that, but, she was saying it in a, appreciative way that people launch after college, they're on their own, they might be in a big city where they're working hard. and they show up and say, well, I Google myself and I think I have chest pain and I might have coronary disease. And you say, well, how do you spend your time? And they're coding late in the night and drinking Red Bulls and staying out late. And then, there's it was coming up in that kind of context, but I'm using it more as an example that the behaviors and mindset obviously apply across age ranges. I do think we shouldn't ignore seniors. There's so much opportunity to create more prevention and early risk management and to grant seniors through our effectiveness of support many more years of high quality function in life, which is what we all want. And so, you can be assured that as we go forward, when it comes to constructs like HEDIS, we want to be talking about the important domains of health that we need systematic, uniform, cohesive, and aligned measurement signals about. And that it could include concepts like broadening and prevention. We also just are under final review and public comment of a colorectal cancer screening follow-up measure. And so it's that, if you get screened for colon cancer by a home-based kit, if you screen positive, you actually get the follow-up recommended care. And so I go back to this chain of lights concept that behaviors, activities, are they all chaining together to the next stages of things that happen? And does that lead to the improvement in outcomes and person-centered views of quality and outcomes that we all want in our day-to-day lives and we all strive to give to our patients?
Yes, well, thank you, Vivek. This has been exactly the kind of conversations that I've wanted for a very long time. So I think you've given our listeners a real sense of what's possible when we are willing to ask harder questions. Thank you for your leadership, your time, and your sharing your insights. And to our listeners, keep asking the questions others aren't asking. That's where change happens. If you enjoyed this episode, don't forget to like, subscribe, and leave a comment. Stay connected for more conversations with the clinicians, policymakers, and innovators rewriting the rules of health. One policy, one patient, one bold idea at a time. Until next time, take action, make an impact, and keep flipping the script on healthcare. Thank you.